Well, good evening, everyone. It's just after 5:15, and hopefully more people will come in late, so we'll leave the door open. There will be people online, but I want to introduce with great pleasure my colleague, Professor Jean-Claude Theis, who's talking about the history of artificial joint surgery from ivory to robotics. So here we are. Chris.
Thank you, Terry. Can everybody hear me? You okay? Good. All right. Okay. Good afternoon, everybody. It's a very select audience, but I'm sure there are thousands online listening to the lecture. It's this month's History of Medicine and Science lecture. And thank you, all of you, for attending. I've chosen this particular topic because there are lots of people out there who actually have benefited from joint replacement surgery. And it's an amazing operation, as you will know. And I thought you would be interested in learning more about this surgery, how it evolved from the late 1800s to this day and age, and hence the subtitle From Ivory to Robotics. I will talk mainly about hip replacements, but we'll cover later on, talk a little bit about hip and other joint replacements. Without any doubt, artificial joint replacements have become one of the most successful operations in orthopedic surgery, to the point that a very well-known medical journal, The Lancet, in 2007, called it the operation of the century. And the number of joint replacements being carried out in New Zealand and worldwide are quite impressive. In New Zealand, there are about 25,000 hip and knee replacements carried out each year in the private and public sector together. And worldwide, about 4.3 million joint replacements done each year. And this will probably increase as the population ages and as we are doing more joint replacement in young people. And this surgery is life-changing. And it restores the mobility to patients, gets rid of their pain, those who are crippled with arthritis. And it seems to be also a little bit life-saving because those people who have a hip replacement, it seems to decrease the mortality because they can exercise more, because they can get back to walking and doing their activities of daily living. And exercise is good for your health. So it's life-changing, but also to a certain degree, life-saving. Now, in this lecture, I will first of all review briefly the pre-artificial joint replacement surgery in the 19th century, what was available before we had artificial joints. And then I will have an in-depth look at the evolution of hip and knee replacements from the 20th and the 21st century, and at the end, cover a little bit of what the future holds. Now, this painting in the late 19th century summarizes orthopedic surgery. There was only amputation available to solve limb or joint problems, and there was no anesthetic. Now, limb amputations were mainly carried out at the time as a result of armed conflicts to treat open and also closed fractures, as well as gangrene and infection. It was the only thing available. And in the absence of anesthesia, of course, the operation had to be quick. And it was obviously that it was only possible to do amputations. Fortunately, with the advances in anesthesia that happened during the middle of the 19th century, surgeons got the opportunity to do different operations from amputation, alternative operations. Now, I indicate there ether. Ether was first used in 1846 by William Morton in the Massachusetts General Hospital in Boston. and he was a dentist. And this was followed closely in 1847 by a young obstetrician, James Young Simpson in Edinburgh, who first used chloroform. Now, interestingly, James Simpson tried the chemical on himself and his friends, and after it appears that after inhaling the chemical, they found that a general mood of cheer and humor had set in, but suddenly they all collapsed and only regained consciousness the next morning. It is also said that the mother of the first child delivered under chloroform was so impressed that she christened her child Anesthesia. Not Anastasia, but Anesthesia. And chloroform was also used on Queen Victoria in 1853 by John Snow for the birth of her eighth son, who was son Leopold, who unfortunately died young at 35 as a result of hemophilia B. Now, apart from the anesthetic, the other issue was antisepsis. And that was a big problem because the lack of antisepsis or asepsis resulted in numerous postoperative infections, and a lot of them led to the patient not surviving. Now, Joseph Lister, he was a surgeon in Edinburgh and Glasgow, and he studied he noticed that following operations, there were different stages of inflammation of the wound, and he described this in case of an infection as a putrefaction happening with discharge of pus. He used carbolic acid, which is basically phenol, to disinfect surgical instruments, patient's skin, surgeon's hands, and that found that this led to a reduction of postoperative infections. Now here you can see one of Lister's sprayer and how it is applied during an operation, as you can see here. Now, interestingly, we have a collection of artifacts here at the medical school. We actually have one of Lister's sprayers, but it's not in a nice polished state like this one here on the slide. And those of you who use Washmouth Listerine, well, that's named after Lister, but it doesn't contain phenol. Now, I'm going to talk a little bit about the early attempts at surgical treatment of arthritis, people who have problems with their joints. And in those days, it was not osteoarthritis because the life expectancy was really limited and people didn't live long enough to develop arthritis in their joints. But they had many problems with joint destruction, damage due to infection and tuberculosis. So what did the surgeons of the 19th century have available as procedures to salvage joints? Well, there was amputation, of course. Then there was osteotomy. Now, osteotomy is an operation where you cut the bone either above or below a damaged joint, and you can then realign the limb, allowing the patient to walk again. An arthrodesis or joint fusion, stiffening of the joint, is another operation which has been used in those days, where you destroy the joint and you stiffen it in a functional position, so to relieve the pain and also allow the patient to walk again. And then finally, resection arthroplasty, where you resect both ends of the bone, and that does not only treat the infection like tuberculosis, but also realigns the limb and prevents the patient from walking again. But this time, it preserves the movement, whereas an arthrodesis or joint fusion stiffens the joint. Early excision of a joint was done, the first done actually in the 18th century by Henry Park. He was a surgeon working at the Liverpool Infirmary, and he practiced surgical excision of the knee and the elbow joints back in 1781. And this is a picture of the Liverpool Royal Infirmary. on the left-hand side there. They used to build beautiful hospitals, didn't they, in those days? And another surgeon in London, Anthony White, he was the first to perform an excision of the hip at the Westminster Hospital, again, on the right-hand side there. And these two hospitals were founded in the early 1700s, long time ago. Here are the clinical and operating notes of the knee excision carried out by Henry Park in 1781. He did the operation on a Scottish sailor who was suffering from tuberculosis of the knee. Now, the patient was had so much pain and was so disabled that he wanted Park to do an amputation, to amputate his leg. But Park sort of convinced him that he had another operation which might preserve his limb, and both of them agreed to go ahead with that. So he did the excision of the knee, and the convalescence was described as rather stormy, but it appears that the patient was able to walk with one stick 12 months after the surgery, which was quite amazing. And he was even able to return to sea later on. And this is an astonishing achievement for an operation carried out 250 years ago. And here's the description by Park in his own words where he outlined the principle of joint excision, where the bones of both sides of the diseased joints are removed and allowing not only the infection to heal, but also giving the patient a new joint. Here's the obituary of Anthony White. He was quite an interesting character, but it is said that he was being one of the laziest in his profession, that he was always late for his clinic and his operating list. But despite this, he was enjoying quite a lucrative private sort of surgical practice. Obviously, he didn't write up a lot of stuff, apart from the fact that he gave a Hunterian oration before the Royal Society. Now, in the States, John Barton in Philadelphia, he did the first hip osteotomy for a stiff hip in 1826, and he created a pseudo joint or pseudarthrosis. And interestingly, he performed the surgery without anesthetic in 7 minutes. That's truly remarkable, and the patient survived. These surgeons here from Europe, there's some from Austria, from Italy, from Germany and France, they performed resections of joints and fusions in the late 19th century in the ankle and the hip, again for tuberculosis, but here was somebody doing it for the first time for congenital hip dislocation. Now, this hip resection, where you take out the femoral head or the ball of the femur, was an operation which has survived into the 21st century and was redescribed in 1928 by Garthon Girdleston, a professor of orthopedic surgery at Oxford University. And this was to treat infected hips, bacterial infection or tuberculous infection. And it was, of course, before the advent of antibiotics. And that was all that was available. Now, interestingly, this procedure where you excise the femoral head is still being used mainly in low-income countries where joint replacements are not available. And I have worked in Africa for many years and have carried out this procedure in adults, but also in children to salvage hips which had been destroyed by infection, which is quite common in Africa. Now, the next step towards artificial joint replacement happened in the late 1800s, where some surgeons, rather than resecting the bone, they came up with the idea of putting some interposition of different materials between the two ends of the joints to reduce the pain and preserve the movement. And different tissues were used, as you can see on the slide here, muscle, fat, And it included even pig's bladder in some cases. And I must congratulate these gentlemen on their facial hair, which is quite amazing. John Murphy from Chicago, he used fascia lata, which is a tissue covering the side of the thigh muscles. And he used this in the knee joint, probably in tuberculosis, I would presume. Sir Robert Jones, who's recognized as the father of orthopedics, used gold foil as an interposition material. And he reported a case with a 21-year follow-up stating that the patient retained a good range of motion and had very little pain. Then came this man, a German, Themistocles Gluck. And he's been credited as having developed the first artificial joint replacement made of ivory. His biography shows that he was born in Moldova, which is now part of Romania, in 1853. His father was a physician to the royal family, and he studied medicine in Germany, in Leipzig first, and then in Berlin. He obtained his higher surgical degree in 1882, and a year later became a professor. So obviously, he must have been very good to become a professor 1 year after becoming a surgeon. But he did not get a chair of orthopedic surgery in Berlin, and unfortunately had to return to Moldova. But later on in 1890, he became head of surgery at the Emperor Frederick Pediatric Hospital in Berlin. Now, he was quite an experimental surgeon and did a lot of work on organ resection and transplantation, as well as some animal experimental work in auto and heterologous tissue transplantation. And then he switched and started to work with foreign materials. And he used steel plates and screws for fixed fractured femurs. And he did that mainly in the Serbian-Bulgarian War in 1885-86. He also experimented with bone cement. And as you can see, he used quite a number of different components. And he developed intramedullary fixation and bone defect fixation with ivory cylinders. And he was first to describe a laryngectomy. Now, why did Gluck choose ivory for his artificial joint replacement? Now, first, it is very similar to bone, actually, and it's made up of collagen protein, like in bone, which is called dentine, because it's, of course, you have it in your teeth. I mean, the tusks of the elephant are basically just like our teeth. So it's a collagen protein and hydroxyapatite, which is the mineral content of bone, calcium and phosphorus. So it's very similar to bone. Two, the second reason is it can be carved easily into any shape. And three, it was easily available in those days because most European countries had colonies in Africa. And ivory was the side product of the slave trade. They used to buy the slaves and then use the slaves to carry the ivory out towards the coast to be shipped to the Europe, Asia, Middle East, and the Americas. And fourth, it's strong and allows you to take some weight-bearing load. So quite an ideal sort of product. So he developed the first total knee replacement made of ivory, and he did the first one in Berlin in 1890. Overall, he did 14 arthroplasties, including the hip, but only reported on 3 knees, 1 wrist, and 1 elbow. All of them, again, for TB. And most implants failed due to infection. Here you can see the knee prosthesis, as you can see here, which is very similar to the hinged knee prosthesis which were used in the middle of the 20th century. So it consisted of 2 ivory pieces with an intermedullary stem fixed to the bone with ivory pegs. That's definitely the first joint replacement described. This slide shows the ivory hip implant he designed, as well as the drawing of an ankle replacement. I don't think he managed to develop this one. This was just one of his ideas, but it never was used in reality. Now, in those days, ivory implants used to be very popular amongst German surgeons. And here you can see some examples. There's some rods there which have been used in the long bones to fix fractures, and there are plates as well there. You can see to fix bones. And if you go to the 3rd floor here at the hospital, there's the orthopedic history hall, and there are some of those plates on display, as well as a number of implants I'm going to talk about now. Now, these ivory implants, interestingly, were used in some countries until quite recently, mainly in Myanmar, Burma. And there was a doctor there, or a surgeon there, Dr. Sanbao, who used these implants until the 1980s. He did over 300 of these operations. And on the left-hand side there, you can see on the left hand, there is an X-ray of an ivory hip implant 12 years following the initial operation, and it shows quite a good fixation. There's one French surgeon, Jules Péan, who designed a shoulder prosthesis in 1893, and this was made of platinum and hardened rubber. Right. Now, the main improvements in artificial joint replacements happened actually in the 20th century. And I now take you through this period. Now, hip replacement basically trying to reproduce, to restore the hip joint to normal by trying to replicate the function of the nice, smooth, white articular cartilage. You can see there on the right-hand side of the ball of a hip. However, even the best hip replacement is not a normal hip. And surgeons have to constantly remind patients of that. Nowadays, joint replacements are mainly done for osteoarthritis, and that's a degenerative age-related wear of the articular cartilage and formation of bone spurs around both sides of the articulation, causing pain and stiffness. In advanced cases, the cartilage is worn down to the bone. Now, the other thing is you need to understand the difference between a total hip replacement and a hemi or partial hip replacement. Now, a total hip replacement on the left there is where both sides of the joints are replaced. A hemi or a partial hip replacement is only when one side is replaced, like in the femur, you only replace the ball and the socket is left as it is. Now, so trying to recreate what nature has provided us is challenging. And here's a list of considerations which the bioengineers and surgeons have to grapple with over the years, with implant development. They had to find the right material which was strong enough to bear load. They had to think of the design. They had to devise a way of fixing the implant to the bone. They had to think about wear, because the joint moves, so there are wear particles will be generated. They had to think of the stability of the joint, because you don't want the hip replacements to dislocate. And you have to think of biocompatibility, you know, whether the materials were compatible, were biocompatible. So people thought, the surgeons thought of different designs, and you can see there are a variety of different designs. People came up with these ideas. Interestingly, the one at the top left-hand corner is actually an ivory one, which was first used by Hay Groves in Bristol. It's basically an ivory femoral head, which has got a stem which goes down the femoral neck. And then seemed to be that they focused mainly on the femoral side rather than the socket, which came slightly later. Now then the interposition idea was rediscovered, was redescribed by a chap called Smith-Peterson. So it was described, as I said already, in the late 1800s, but he sort of took that idea back and he developed what's called a mold arthroplasty in the 1920s and 30s, where he used different materials to form a mold, materials like glass or bakelite, and eventually he used Vitalium, which is a metal alloy. And these cups were manufactured in different sizes and placed between the femoral head and the socket of the pelvis. And here's an X-ray. You can see them there sitting on top of the femur. But unfortunately, this resulted in migration. I mean, gradually the articular cartilage of the socket was worn, and these implants used to migrate inside the pelvis and basically failed. This man here, Austin Moore from South Carolina, he developed a hemi hip replacement, which was very popular, as you can see there. So a ball and a stem, which goes inside the medullary canal of the femur. And this was mainly used for hip fractures. Some hip fractures or neck of femur fractures can be fixed and they heal, but others don't heal, and they are normally treated with an artificial femoral head. This became very popular. And when I started here as a consultant in the late 1980s, that implant was used here for hip fractures. This implant is actually still manufactured. When I was working in Africa a couple of years ago, I actually used this one for neck of femur fractures where I worked in Malawi. Now, he was very proud of his prosthesis. Dr. Moore was very proud of his prosthesis, to the point that he used it as a hood ornament on this beautiful Chrysler Imperial convertible. There you go. Another surgeon in New York, another American, Thompson, he designed a similar implant, but this one here was for cementation. You had to use cement to put it in. And this implant was used in Dunedin until the early 2000s. So the Thompson, again, for neck of femur fractures. Now, this guy here is Sir Philip Wiles, a British surgeon from Bristol. He was actually the first surgeon to do a total hip replacement, where both sides of the joint were replaced, the socket and the femoral head. And he used this metal cup, which was fixed into the socket, used a metal head and a stem which went down the neck of the femur, and that was fixed to the side of the thigh bone with a plate and screws. And it was a metal-on-metal articulation, so there was metal articulating against metal. So he did that at the Middlesex Hospital in London in 1938, the first true total hip replacement. Over in France, there were two brothers, Jean and Robert Judet. They were also working on the design of a hip implant. They opted for an acrylic femoral head replacement. And they first implanted that shortly after World War II in 1946. However, they had problems with fatigue fracture of the stem. The stem used to break, so that later they had another version of the same implant where they put a metal rod inside the stem to reinforce it to prevent the fatigue fracture. Now, acrylic is also better known under the name of plexiglass. And at the display on the third floor, there are a number of those. You can have a look at them if you want to. As a result of this fatigue failure, they changed the design and used metal, Vitalium prosthesis in 1948. Vitalium is an alloy of chrome, cobalt, and molybdenum. And they claimed that, I mean, that certainly improved their outcome. And here's a report of a 40-year follow-up of a patient with a first generation acrylic Judet prosthesis. However, it failed, most failed due to loosening of the fixation, fracture of the stem, and wear of the socket and pelvic migration, which is the problem of replacing only the femoral head and not the acetabulum. It's the problem of a hemi-hip replacement. In the 1950s, English surgeon George McKee and Canadian John Watson Farad, they developed this time I mean, a little bit like Wiles and a cemented metal-on-metal hip replacement. And you can see the similar design of the femoral component to the Thompson and the Moore prosthesis. Now, this also failed in the long term because of the metal wear particles forming between the femoral head and the acetabulum. And that caused loosening and bone loss around the implants, and they failed. Now, when I was a young trainee in Europe, I assisted a lot of revisions of these implants, and it was, you opened up the joint, and there you had this tumorous, like it looked like a tumor, a mass of green granulation tissue surrounding the implant, and that was the typical finding from the wear particles, the chrome cobalt wear particles, and it was not a very good look. Finally, there came this man, another Englishman, John Charnley from Manchester. Now, he worked in Wrightington Hospital near Manchester, and he developed a concept of what's called low friction arthroplasty. And eventually, after many challenges, he actually designed the first successful cemented metal on hard plastic total hip replacement. His innovation was the introduction of a small femoral head. You see, quite small, 22 millimeter in diameter. And that was to reduce the friction between the metal head and the plastic cup in order to minimize the shear forces at the cement bone interface with the aim of preventing long-term loosening of the acetabular cup. And it was Charlie's engineering mind which had a defining influence on his work as an orthopedic surgeon. He was actually, he combined his understanding of mechanics and the material science to solve the biological and engineering challenges to develop his hip prosthesis. Initially, he used Teflon as a plastic cup, but that was a disaster because it wore rapidly, leading to failure of the procedure. As a result of that, he changed to a different plastic. He changed to a wear-resistant plastic in the form of high-density polyethylene, and he implanted the first prosthesis, such a prosthesis with an HDP cup in 1962. Here you can see that the Teflon cup, which wore very rapidly, and on the right-hand side is the high-density polyethylene Charlie cups. Now, this is what it looks like on an X-ray, and I personally used the Charlie hip here in Dunedin for many years with good results. It was a great prosthesis. So on the X-ray, you can see there the femoral stem, the small head, and it's cemented in place, and the plastic cup, you can see that there. Now, Charlie used acrylic bone cement, which came from the dentist. The dentists were using this cement, and he used it for fixation of implants, for fixing the plastic cup to the socket and for fixing the metal stem to the femur. Now, acrylic cement is made out of two things. One is a powder, which is methyl methacrylate, and a monomer liquid. And when you mix them, you get a polymerization reaction. And as the cement, and then the cement gradually hardens in about 5 to 10 minutes it takes for it to harden. Now, this cement is still currently used. And please note, the cement is not a glue, it's actually a grout, and it's injected under pressure to fill the gap between the implant and the bone. Charnley also was aware of the catastrophic consequences of postoperative infections with joint replacements. And it basically, if you got an infection, that meant you had to take the implant out, and then you had a difficult infection eradication process to get rid of the infection in the bone. He designed what's called a Charnley tent, which you can see there. And this is actually Charnley operating there on the left-hand side of the slide. He designed this, and this is basically an enclosure with a laminar airflow where filtered air is pumped into that tent, and the air is exchanged rapidly, and the surgeons and the instrument nurse wear a sterile total body gown, which covers you from head to toe, called a spacesuit, to create a clean air environment for the surgery. And note the anesthetist, there's one up there, the anesthetist is outside the tent, and the patient's head is outside as well as the circulating nurse. Now, as a result of these precautions, the infection rate dropped dramatically. Now, here I have to pay tribute to the late Professor Keith Jeffrey, who was my predecessor and mentor, who was the first surgeon here in Dunedin and probably in New Zealand to carry out hip replacement surgery. Now, Keith spent some time in England, including visiting Charnley in Wrightington. Now that Charnley had designed the first successful total hip replacement, the challenge for the surgeons and the engineers, the bioengineers, was to increase the longevity of those artificial joints. And the main issue with artificial joints, like any artificial mechanical device, is wear. Now, I listed here the factors which influence wear, and they include surface finish. A very polished finish has less wear than a rough finish. The material properties, if the material is soft, it will wear quickly. Lubrication is important to reduce the number of wear particles. The size of the femoral head as well. The bigger the head, the more wear you get. And the patient weight. The heavier the patient, the more wear happens in the joint. And here you can see the effect of wear on polyethylene plastic in a knee replacement. This is some implants I have retrieved from patients. Now, under B is the normal polyethylene insert for knee replacement. And you can see how they wear, and it's not a good look, not pretty. Now, materials have different wear characteristics, and that will determine their coefficient of friction. So you can see here the natural hip, of course, is ideal. And then the other materials trying to get as close as possible to the natural hip coefficient of friction. And it looks like the ceramic on ceramic is the best as far as coefficient of friction is concerned. They seem to get closest to the articular cartilage. Another pioneer in hip arthroplasty was Maurice Müller in Bern, Switzerland. That's him there. And he used cemental total hip replacement and was inspired by Charnley, but he preferred a larger head, a 32 millimeter head. And his femoral head and stem looks very much like the Moore and the Thompson prosthesis, except that his stem was bent like a banana, and we used to call it the banana hip. Now, cement fixation came into disrepute as the long-term failure of implant was put down to cement. This is actually not true. It's the wear particles which lead to the failure of the artificial joints. And the so-called cement disease, this was called cement disease, actually led to the surgeons and the engineers to look at more biological fixation without using cement, where bone grows directly into or onto the rough surface of the implant, and no cement is used. And two French surgeons, Lord and one of the Judet brothers, were early pioneers of this technique. Now, interestingly, again, this came from the dentist, because the dentist had been using these dental implants, which are screwed, titanium screwed into the mandible, as you can see here, and then the tooth is placed on top. So again, like the cement, this cementless fixation came also from the dentist. These are some Judet porous coated implants. They had very rough surfaces, and the bone used to grow in quite well, but it led to what's called stress shielding with bone loss, as you can see here on these X-rays, where although the proximal part of the femur was resorbed, and also quite a lot of bone resorption around the cup. So that failed as well. Now, the weak part of a hip, total hip replacement, is always the acetabulum. And that's why people have looked at different designs, different materials, different ways of fixing these to the bone, including there's one acetabular cup made of ceramic, which was screwed into the acetabulum, but most others were press fit. The other improvement in implant fixation came through better implant coating to make the implant rough so that the bone can grow into. And they used beads and mesh and also hydroxyapatite, calcium and phosphorus, sprayed directly onto the implant to allow the bone would recognize this as part of, the bone mineral content, hydroxyapatite, calcium and phosphorus. And it was sprayed on in a thin layer. And here you can see some examples of, you can sort of put some titanium mesh on it, or beads, and on the other side is the hydroxyapatite. I had the opportunity, fortunately, to retrieve at a postmortem an implant I inserted 10 years prior. Now you can see I did this femoral implant at autopsy or at postmortem. The femoral implant was resected en bloc, so the implant inside the bone, and it was submitted for microscopic analysis. I always remember that patient who told me, "You can have the implant when I die." And that is exactly what happened when he died. I was allowed to take out his implant. The other thing I remember about this guy is that he was a very good fly fisherman. And every time he came to my clinic, he brought me a nice trout. So I never discharged him. So here you can see on the left-hand side, that's his hip, quite worn, osteoarthritis. In the middle is the implant. It's an titanium implant coated with hydroxyapatite proximally of the femoral stem. The cup, titanium, and sprayed with hydroxyapatite, and the femoral head was ceramic. And the post-op X-ray. The left is the X-ray of the explanted implant with the femur intact. And on the right is the histological process. So you need a diamond saw to be able to cut the bone with the implant inside you. And here on the right, you can see a macroscopic view where you see in the center is the metal stem. And you can see the bone surrounds the stem very well. There's very nice bone surrounding it, but no hydroxyapatite left. And on the left-hand side is the histological section, where you can see the bone lamellae growing right up to the metal without interposition of any fibrous tissue. There are also different bearing surfaces which have been tried. You know, there's been metal on plastic, metal on metal, ceramic on plastic, ceramic on ceramic, metal on ceramic. Everything has been tried. And here, for example, there's a ceramic on ceramic hip implants. There are 4 pieces. There's the stem, there's the femoral head is ceramic. The liner for the socket is ceramic, and then the metal cup for the which fits into the pelvis is metal. So most components now, rather than 2 components, there are 4 components and sometimes more. So the surgeon has many choices to fit prosthesis because the anatomy, the size of the bones, the acetabulum varies. And it's very much like if you go and buy shoes, they have different sizes because people have got different sizes feet. However, what is new is not always better. And in the early stages, there were quite a number of fractures of the ceramic on ceramic implants. However, they changed the ceramic, and now using zirconium, this has made these events very rare now, and that problem has been fixed. So that was basically the hip replacement, the story of the hip replacements. Now, briefly, total knee arthroplasty had a similar timeline, although it lagged behind a little bit in the early stages. And basically, that's a typical knee replacement. The femoral component replicates the curve of the distal femur. The tibial component reproduces the flat surface of the tibia, and then there's a piece of polyethylene, high-density polyethylene in between, which is fixed to the tibial component. Normally, the patella, we leave that unsurfaced, although there are patella resurfacing buttons available. Other replacements, shoulder, ankle, elbow, wrist, fingers, hallux, spine are available, but used much less than hip and knee replacement. Here's a shoulder replacement, the standard one on the left, and what's called a reverse one in those people who have got ruptured rotator cuffs. You need to have the rotator cuff to be able to get the one on the left, the standard one. If your rotator cuff is not working, then you need a reverse shoulder replacement there. Ankle replacements are rare because arthritis in the ankle is not very common. There's one example there, X-ray, postoperative X-ray. Elbow replacement only in cases of rheumatoid arthritis, because osteoarthritis of the elbow is very rare. Now, these elbow replacements are very rare now because rheumatoid arthritis is not very well treated by drugs, and it is now rare to get to the point of joint destruction. Disc replacements are available in the lumbar spine, the cervical spine, but the clinical results are quite variable. And then these little silastic finger joint replacements, they actually have been around for a long time, and they're only used for rheumatoid arthritis, like in the hand there, the patient with quite severe destruction, arthritis of the knuckle joints, with the fingers drifting and stiff. And then with the joints in place, you can see the fingers straighten out and improve the function and the grip strength. Now, the outcomes are quite remarkable. Just summary here. These are reports from 2019. Total hip replacement, 85% survive at 15 years. And then it drops down a bit, 78 at 20 years and 77% at 25 years. But it's still remarkable. Total knee replacements, there are some unicompartmental replacements where you only replace one side, and the total ones where you replace the whole knee. Unicompartmentals don't do as well at 25 years, 70%, but total knee replacements at 25 years, they do remarkably well, 82% survive. Now, this is one of my papers where we looked at implant failure requiring a revision based on age at initial surgery, over 4,000 patients. So if you are over the age of 77 and you have a hip replacement, you got 90% of chances of dying before your joint wears out, so you won't require a revision. However, if you are under the age of 50, when you have a joint replacement, you got a high chance that you will require further surgery, 1 or 2 or more revisions. And if you're around 58 or 60, you got a 50% chance. Now we're doing more and more joint replacements in younger patients, so the revision load will increase, and it's a more expensive, more difficult operation, and we'll see the number increasing. Recently, further advances in implant techniques to implant the components, mainly for knee replacement, have been developed. And the positioning of the knee components are very crucial, and the implants have to be perpendicular to the axis, the weight-bearing axis of the leg. And to do this, there is a computer technology which can help you in the accuracy of implanting those implants. But so far, it has not shown that there is improved long-term clinical outcomes, because with joint replacements, because they last so long, you really have to wait for many years before you know whether one is better than the other. And then here, finally, the robotic surgery, which is available mainly for knee replacements. They do not do the surgery. It's robotic-assisted surgery, where the robot helps you in doing the cuts, guides the surgeon's hands in doing a better cut, and that requires a preoperative CT scan, which will be computerized, and then you get a digital reconstruction of the patient's knee. So the robot knows exactly where to do the cut. Finally, in conclusion, just a few quick look at the future. What is there in the future? Well, some surgeons and many bioengineers have been experimenting with 3D printing of custom implants for each patient, individual patients, because people are different. Looking at improved materials, yes, smart implants, where the implant gives you feedback, whether it's going well or whether there are problems. Artificial intelligence, yes, that's around everywhere now. And then alternative to joint replacement, like tissue engineering, cartilage regeneration, genetic engineering of osteoarthritis, and medical treatment of osteoarthritis. Now, of course, we as surgeons hope that that won't happen. Otherwise, we will be out of a job, okay? So this covers the evolution of joint surgery over the last 250 years. And hopefully you will understand that modern artificial joints did not fall from the sky, but are the result of pioneering work by many surgeons and engineers who have worked their whole life dedicated to this, to allow patients suffering from disabling arthritis to throw away their crutches, their painkillers, and walk again. So thank you very much. And yes, complications can happen. Thank you.
Thank you, Jean-Claude. I have a question, first of all. What is the basic consideration between a cemented and non-cemented hip? You said that the cement doesn't contribute to fragmentation or extraneous particles in the joint.
No.
So why do you think that cementing it would be better than non-cementing?
Well, no, it's not the cement. It's the wear particles, and that the wear particles, they cause some reaction of osteolysis, where the bone is resorbed around the implant. Now, if it's non-cemented, it is resorbed around the metal. If it's cemented, it's resorbed around the cement. It's the implant bone interface or cement bone interface. Now, there are other considerations. There's surgeon's preference, cost, and it's much quicker to put it uncemmented in, because you don't need to put the cement in and wait 10 minutes for the acetabulum and another 10 minutes for the femur. So whether you cement it or whether you do not cement it, they fail because of the wear particles and loss of bone, and the implant becomes loose, and then the pain comes back.
Any other questions? we don't seem to have access to those people who are online. So I'm sorry about that. Yes.
Yeah.
Oh, you're sorry.
Found it extremely interesting, and I enjoyed it enormously. Well, I've got to breathe into it. Could you just summarize the evolution of the surgical technique to approach the hip joint? Because there was problems when the prosthesis, in fact, would dislocate, and new techniques were developed. Am I correct there?
Yeah. Well, I mean, first of all, it's the approach, how to get to the hip, you know. You can get to the hip from the front, from the side, or the back, okay? From the front, it's more recent. Most of the hip replacements in New Zealand are put in from the back because it's relatively easy. You can get between the muscles. You don't damage the muscles too much, but you've got a higher risk of dislocation. I've always used the approach from the side, where you interfere with the abductor muscles, the muscles which contribute to the stability of the hip. But there are less dislocations compared to the posterior approach. That's the approach. And then, of course, the design of the implant will also, the way the implant is put in, you have to put it in properly in the proper orientation. If it's not, if the socket is facing forwards, then the hip will dislocate anteriorly. It has to be implanted in a certain position to mimic the normal anatomy. And the size of the head will also determine whether it will dislocate or not. The smaller head has bigger chances of dislocating than a bigger head. So there are, I mean, postoperative instability is an issue, but it's multifactorial. It's the approach, how do you get to the hip? It depends on how you position the components and the size of the femoral head.
Similar to that question, from your experience, how has the post-operative care of hip replacement patient changed?
Okay, good question. When I first started here, there was one surgeon who put the patients into a hip spica, a plaster. You know, that was in the 1950s or 60s. People were concerned about dislocations and things like that. And then they were told that they have to stay in bed for 1 to 2 weeks before they could go home. And then gradually, as the surgeons became more confident with their surgery, they discharged them quicker and quicker, to the point that in some centers in the States, they do it as a day case. But they take the hospital home, you know, because it's much cheaper for the patient to be at home, but they provide all the nursing services, everything, you know, the pain relief. They go home with an epidural and everything. So people are now get up the same evening after the operation, okay, to get them mobile. Also prevents complications like deep vein thrombosis and things like that. So patients are now mobilized very quickly, the same day, and they go home after day 2 or 3. They walk with crutches for 4 to 6 weeks, but they're encouraged to get going as quickly as possible. Oh, no, I mean, I'm talking about the 50s or 60s, where patients were in hospital for 2 weeks, but that has changed over the last 30, 40 years. Yeah, much quicker rehabilitation, very fast.
Any other questions? If there are no other questions, please join me in thanking Jean-Claude.
Thank you.